Hi everyone, welcome to my channel, Integrated Med Notes. In this video, I will discuss about superior vena cava syndrome, or SVCS. Superior vena cava syndrome occurs when blood flow through the superior vena cava, or SVC, is obstructed. This obstruction can result from one of several mechanisms. 1. Thrombus formation within the SVC. 2. Direct invasion of the wall of the SVC by tumor cells. 3. Extrinsic compression of SVC as a mass effect from an adjacent pathological process such as a tumor. Both malignant causes and benign causes, such as thrombosis and fibrosis, can block blood flow through the SVC. 1. Malignant causes of SVC. Intrathoracic tumors can cause SVC obstruction either by extrinsic compression or by direct tumor's invasion. An intrathoracic malignancy is the most common cause of SVCS, accounting for about 60% of all cases of SVC syndrome. The most common malignancies associated with SVCS are lung cancer, 85%, and mediastinal non-Hodgkin lymphoma. Other less common malignant causes include thymoma, mediastinal lymph node metastases, primary mediastinal germ cell tumors, and mesothelioma. Because of its higher incidence, non-small cell lung cancer is a more frequent cause of SVC syndrome overall than is small cell lung cancer, but SVC syndrome tends to occur more frequently in patients with small cell lung cancer due to its central location and aggressive growth pattern. 2. Non-malignant causes of SVCS. The SVC can also be compressed by mediastinal lymphadenopathy, which can be caused by sarcoidosis or fungal infections and result in lymph node enlargement that compresses the SVC. Thoracic aortic aneurysm can also directly compress the adjacent SVC. Another cause is chronic fibrosing mediastinitis. Chronic inflammation of the mediastinum can lead to excessive proliferation of connective tissue, or fibrosis, within the mediastinum and around central vessels. Causes include histoplasma capsulatum, the most common cause, tuberculosis, Behçet's disease, and prior radiation therapy. Radiation therapy can cause vascular fibrosis of the SVC, leading to vessel stenosis and reduced blood flow. Another cause is thrombosis. Blood clots within the SVC can obstruct blood flow. Thrombosis more often develops in patients with long-term intravascular devices, such as central venous catheters or pacemaker wires, which act as a nidus for clot formation. Any medical device placed in the subclavian or internal jugular veins will predispose blood clot formation in SVC. As more patients are placed with intravascular devices, device-induced SVCS is becoming more common cause. Other causes of thrombosis include hypercoagulable states from malignancy, systemic lupus erythematosus, or rarely, antithrombin 3 deficiency. Anatomy of SVC. To understand SVC syndrome and SVC obstruction, it's important to review some basic anatomy. The brachiocephalic, or innominate, veins are formed by the union of the ipsilateral internal jugular veins and subclavian veins. The left and right brachiocephalic veins then merge within the mediastinum to form the superior vena cava, SVC. The SVC is a short, large vein located on the right side of the mediastinum. It drains blood from the head, neck, upper chest, and both upper extremities, delivering this blood to the right atrium of the heart. Understanding this anatomy is important because any mass lesion in the mediastinum or in the lungs can compress or obstruct the SVC, causing blood to back up into the veins that drain the upper half of the body. Pathophysiology of SVC syndrome. Regardless of the underlying cause, when the superior vena cava gets obstructed, behind the obstruction, there will be an increased venous pressure in the vessels that drain into the SVC. As a consequence, blood is rerouted through alternative pathways, called collateral blood vessels, that eventually return the blood to the right atrium via the inferior vena cava. Collateral veins may arise from the azygos, internal mammary, lateral thoracic, paraspinous, and esophageal venous systems. Over several weeks, these collateral veins dilate. As a result, the upper body venous pressure that was markedly elevated initially starts to decrease a bit over time. However, even when well-developed collateral drainage patterns are present, the central venous pressure still remains higher than normal, producing the characteristic signs and symptoms of SVC syndrome. How rapidly the SVC is compressed determines whether venous collaterals can adequately compensate for the narrowing, which in turn determines the presence and severity of the symptoms and signs of SVC obstruction. Patients with malignant disease may develop symptoms of SVC syndrome quickly because rapid tumor growth does not allow adequate time to develop collateral flow. By contrast, fibrosing mediastinitis as a cause of SVC occlusion may not become symptomatic for years. Symptoms and signs of superior vena cava syndrome, or SVCS. SVCS results from obstruction of the superior vena cava, impairing the return of venous blood from the head, neck, and upper limbs to the heart. This reduction in venous return leads to decreased preload and reduced blood flow to the lungs, resulting in dyspnea and hypotension. Meanwhile, behind the obstruction of the SVC, there will be backup of venous blood that results in venous congestion and increased venous pressure in the vessels that drain into the SVC. This increased venous pressure in those vessels results in edema, where fluid leaks out of the blood vessels into surrounding tissues. Clinically, this manifests as head fullness and a flushed or red facial appearance, swelling of the face, neck, arms, and upper chest. The facial swelling or head fullness can be exacerbated by bending forward or lying down. Physical examination shows jugular venous distension, blanching skin above the clavicle, engorgement of subcutaneous veins, and erythema in the face, neck, chest, and both upper limbs. The elevated venous pressure and edema can also result in compression of other structures. For example, edema or excess fluid can compress the trachea, larynx, or other upper airway structures and lead to dyspnea, stridor, cough, or hoarseness, while fluid accumulation around the esophagus can cause dysphagia. Additionally, the increased venous pressure may cause cerebral edema, leading to increased intracranial pressure, with symptoms such as headaches, confusion, visual disturbances, and in severe cases, complications like retinal hemorrhage, stroke, or even brainstem herniation. These complications make superior vena cava syndrome a medical emergency. Brachiocephalic vein obstruction. The brachiocephalic, or innominate, veins form from the union of the internal jugular and subclavian veins on each side, and they merge to form the SVC. Obstruction of a brachiocephalic vein produces similar symptoms to SVCS, but only on one side of the body, leading to ipsilateral swelling and venous engorgement of the face, neck, and arm. In SVCS, however, the obstruction affects both sides, causing bilateral symptoms in the face, neck, chest, and arms. Diagnosis of superior vena cava syndrome. If superior vena cava syndrome is suspected, diagnosis can be done with imaging, such as chest X-ray or CT scan, that can help to identify the SVC obstruction and look for the underlying cause. Chest X-ray may show mediastinal widening due to a mediastinal mass near the SVC or a right hilar mass. Contrast-enhanced computed tomography (CT) of the chest is the best imaging method to evaluate and diagnose superior vena cava syndrome. A chest CT scan with contrast will show a large filling defect or obstructed SVC, define the site and level of SVC obstruction, and identify the presence of collateral vessels. Additionally, CT imaging may help to identify the underlying cause of SVC obstruction. Treatment of superior vena cava syndrome, SVCS. The goals of treatment of SVCS are focused on restoring blood flow through the SVC to alleviate symptoms and treating the underlying cause of the obstruction. General measures. Head elevation. Keep the patient's head elevated above the level of the heart. This helps decrease hydrostatic pressure and reduce head and neck edema because of gravity promoting venous drainage. Fluid management. Avoid overhydration, which can exacerbate venous congestion. Diuretics may be used as needed, but care should be taken to avoid depleting intravascular volume. In patients with no life-threatening symptoms, treatment depends on the underlying cause. In malignancy-associated SVCS, based on biopsy results, the tumor may be treated with radiation and chemotherapy to reduce the tumor size, alleviate compression of SVC, and hence reduce the symptoms of SVCS. In addition, sometimes steroids can be used to reduce swelling around the tumor. In thrombosis-associated SVCS, where the cause is a blood clot within the superior vena cava, the most important step is to remove the causative device, such as a central venous catheter. After the device is removed, anticoagulants can be used to limit thrombus extension. In patients who present with life-threatening symptoms, they require immediate intervention. Patients with life-threatening symptoms are those with symptoms such as stridor due to central airway obstruction, severe laryngeal edema, respiratory compromise, or altered mental status from cerebral edema. After initial stabilization, secure airway, support breathing and circulation, these patients require endovenous intervention to restore venous return and decrease the risk of sudden respiratory failure and death. The endovenous intervention includes emergency thrombus removal and endovenous recanalization via mechanical or pharmacologic thrombolysis and SVC stent placement. After endovenous intervention, the next step is treating the underlying cause of the obstruction. Thank you for watching this clinical overview. If you found the video helpful, please like, share, and subscribe, and don't forget to leave your comments below. Until next time, happy studying and good luck.